It's not a secret now that patients who have cancer are at risk for heart problems. Wall Street Journal, a prominent journal, of course, said which to treat, cancer or heart problems. Um, Washington Post, breast cancer treatments can raise the risk of heart disease, American Association warns. And so most patients now are quite aware of possibilities that they may be getting into with their cancer and the treatment of cancer. The survivorship numbers are happily growing in the United States. This was actually a slide from 2016, but extrapolated to the future. The color bars or areas are age range. And you can see that in all age ranges, the number of survivors is growing and is in the millions. So this is something that's relevant for a lot of people. Um, for breast cancer, the American Cancer Society recently put out their figures for survival. SEER is the Surveillance, Epidemiology, and End Results Program, which provides huge numbers of patients from which this data can be extrapolated. And I'm not intending to put too many charts and graphs in, but some of these I thought you might be interested. So at this point, people with localized breast cancer, their 5-year relative survival rate is as high as 99%. And even with regional spread and sometimes with distant spread, 5-year survival is high enough that any patient with this problem can be hopeful that they'll be a survivor for a long, long time. So what about the heart? So this is a graph, and what you see on the bottom is years after the diagnosis of cancer, and on the y-axis is survival, and is prevalence of disease, so mortality. And you can see that survival goes down as we all would expect with time, but you can see that the risk of dying from breast cancer actually, after about 10 years, is less than the risk of dying from CVD, which is cardiovascular disease. And this is why graphs like this is why people sometimes say that the risk to women with breast cancer after a few years, 10 years, they are more at risk for cardiac death than they are from cancer deaths. So an important field. Why are cancer survivors at risk for cardiovascular problems? Well, some cancer treatments result in increased risk. Chemotherapy, hormone therapy, radiation therapy. This is an example of just to show that, and I think in a kind of a dramatic form. These are from childhood survivors of childhood cancer, the incidence of cardiac complications in survivors of childhood cancer. And it becomes clear in this population because they generally live a long time. So you'll see that CTX here means potential cardiotoxic therapy, which includes anthracyclines. This is the adriamycin, doxorubicin, or radiation. Now remember, this is not for breast cancer. This is for childhood cancers, which are more commonly leukemias and lymphomas, and that are treated with higher doses of anthracyclines and radiation. But as it became apparent with time that in kids who, and this started counting after they had survived for 5 years. So what you see is people that did not get the potential for cardiotoxic therapy, their survival was good. People who did get the cardiotoxic therapy, their cumulative incidence of heart problems went up over time. And so this is to make the point that these therapies do pose risk for those that receive them. Now, what's happened, of course, is that oncologists learned this and altered the doses of the anthracyclines, finding doses that are effective with low risk of toxicity. The radiation oncologists know about this and have known for decades and alter the way they give radiation therapy either doses or planning so that they avoid giving therapies to the heart. Excuse me. So the risks for breast cancer are not this high, but it is worth noting that there is still some risk. We are blessed with many cancer treatments, but there are adverse cardiac effects from these treatments. And I suspect most of you all are not going to be able to read this on a phone or a computer, but and I'm not going to read it either, but what it goes through is all the different classes of cancer therapies, anthracyclines, Herceptin and similar drugs, targeted therapies. And these are different classes, radiotherapy, alkylating agents, transplant, immune checkpoint inhibitors. And you can see that each of these classes of drugs has some potential cardiac effects. Happily, in a way, most of the effects for these drugs occur while patients are getting the therapies. And once the treatments are over, the risk of the heart seems to go away. But as we'll mention a little later, some of these therapies, the risk persists for decades, and like I showed you for the childhood cancer survivors. So why are cancer survivors at risk for cardiovascular problems? So we mentioned that, and these are survivors, so long-term survivors. And we mentioned that chemotherapy, hormone therapy, and radiation therapy can cause problems. But also, the survivors are subject to the same cardiac risk factors as everyone else. And we're going to spend some time on this later. Age, family history, physical inactivity, tobacco use, high blood pressure, high cholesterol, diabetes, obesity, stress. So all of us, not just cancer survivors, but all of us are at risk for cardiac complications. And I want to spend some time giving some perspective on how to lower the chances of heart problems by dealing with these risk factors. So a minute about what's now my field, cardio-oncology. So it's sort of a technical definition, but a field within cardiology dedicated to the evaluation, management, and prevention of cardiovascular complications in patients with cancer. And cardiologists nowadays get involved in cancer patients at all stages of their cancer journey. So after the initial diagnosis, and cardio-oncologists can help plan therapies, particularly in patients who already have cardiac issues and now they are diagnosed with cancer. What's the best, safest, and most effective treatments for them? During therapy, if cardiac complications develop, we can be called to help. And our goal in this is always to treat the heart problem quickly and find therapies that will rapidly, that will allow resumption of the cancer therapies. We don't want to interrupt treatment for cancer any longer than absolutely necessary. And then following completion of therapy, when patients become survivors, then we are in the survivorship phase and we want to monitor for long-term cardiotoxicity and try to prevent it as much as we can. So I'm going to talk about potential cardiovascular problems in cancer survivors and in everyone else. But the three main problems are going to be weak heart muscle, so cardiomyopathy, congestive heart failure, blockages in the circulation to the heart, coronary artery disease, and then blood clots, deep vein thrombosis, and pulmonary emboli. And we'll talk about each of those conditions. The way I like to do it is discuss the problem and hopefully give you some basic understanding. And many of you already probably have that, but at least go over it again. Some of the possible causes that can arise from cancer treatment. What are the symptoms of these cardiovascular problems? What tests are available to diagnose the problems, and then what treatments are available? And again, this, if we really went into all the details, this would be about a 4-day course. So we're going to hit the high points, but there'll be time for specific questions at the end. So weakened heart muscle. So just a refresher. So this is a schematic of the heart. And what we focus on mainly is what I'm outlining here, the red chamber that's called the left ventricle. And it fills up with blood in diastole, we call it. And then the heart squeezes, and then you can see the left ventricle is smaller. It's squeezing blood. It's directing blood in the direction of the arrows out the aorta. And then it relaxes, fills up again as blood flows in through this mitral valve to fill up the left ventricle, squeezes down again, blood flows out, fills up again, squeezes, etc. And that's goes on all our life. And that's how blood is pumped out to the rest of the body. One of the ways we look at this is echocardiogram, and this is showing normal heart function. And I've told you about the left ventricle. This is like slicing a loaf of bread with an ultrasound image across the left ventricle. And you can see this filling up, squeezing down, filling up, squeezing down. And you can see that some, but not all of blood is pumped out of the heart each time. We quantitate that by a number that's called ejection fraction, and that's left ventricular ejection fraction. It's a percentage of the blood that's squeezed out every time the heart beats. And you can see this is a normal ejection fraction. It's probably 55%, something like that. Anything above 50% is normal. But here we have a heart muscle that's weak. Again, the left ventricle, and perhaps you can see that now not such a high percentage of blood is squeezed out. This is the blood inside, and this is the muscle squeezing. And here, probably maybe 15% is squeezed out. So this is a left ventricular dysfunction. It's called a cardiomyopathy. And the result of this can be a clinical symptom that can show in several ways. So shortness of breath with exertion. If it gets worse, shortness of breath, even lying down, swelling in the legs can be a symptom of congestive heart failure. Now, I would, especially with saying swelling in the legs, would tell you that most of the time swelling in the leg is not due to congestive heart failure. So people have venous insufficiency, lots of reasons for that. So I don't want you to think, gee, my legs are swelling up, I must have congestive heart failure. It's probably not, but it is something to be aware of. So we talked about tests, and there are a number of tests that we can look for. An echocardiogram, and I showed you a picture of an echocardiogram. MUGA, which stands for a multi-gated acquisition cardiac scan. It's an older way of measuring ejection fraction. And then cardiac MRI is a newer way. It took everybody, I think, knows what MRIs are, the knees and the back, and it took a while to figure out how to do it with the heart because the heart's moving. So there had to be a lot of technical advances to do that. But now cardiac MRI is becoming more and more the gold standard for examining the heart. And then there are treatments for the weakened heart muscle. Diet, which is a low salt diet mostly. There are medications, long list, including diuretics, but lots of new medicines that are effective in treating the heart. And then when it gets to a certain point, there are devices that we use, like ICDs, which are implantable cardioverter defibrillators, pacemakers, artificial heart, cardiac transplant. So there are therapies available for the weakened heart muscle in its various stages. This is just one example of effects of therapy so this is months from the diagnosis on the x-axis. And this is survival in percent of patients. And this is to look at the effect of carvedilol, a drug, on survival in severe chronic heart failure. And notice the severe chronic heart failure. So the darker line is placebo, and these are patients given sugar pills versus carvedilol. And you see with placebo, as time goes on, survival drops. Well, it drops with carvedilol, but not nearly as much. And this is a drug that improves survival, improves how patients feel, and strengthens heart muscles for people with who have weakened heart muscle. And there are a number of other drugs, so there's a lot to do to help nowadays with patients who have this problem. So next problem is coronary artery disease. Um, so this is a drawing of the heart, and this is the aorta, big vessel carrying blood to the body. These branches go to the brain or to the arms, but these are the branches that come back and carry blood to the heart muscle itself. Being a muscle, the heart needs oxygen, and it gets oxygen from arteries, and these are called coronary arteries. So when problems develop, you hear the term coronary artery disease. Now I'm going to show you a couple of pictures. If we take one of these arteries and slice it like we slice a loaf of bread, this is what a normal coronary artery looks like. There is some muscle tissue around it, but it's mostly open. Blood flows through and goes out to those branches and carries the oxygen and nutrients to the heart muscle. But people can get blockages in these arteries. And this is the left anterior descending coronary artery, which is one of the ones that I showed you, that has fibrosis after chest radiation. And you can see how instead of being wide open, there's a very narrowed space where blood can flow. And if this gets completely cut off, there in many cases there's damage, and downstream the heart muscle is not getting the blood and the oxygen it needs, and it can be damaged. That's what a heart attack is. This is a CT scan just to show you in a real heart, a patient who had 41-year-old man who had mediastinal, which is chest, middle of the chest radiation therapy for lymphoma. And you can see where I've magnified it up that one of his arteries has two paces of bad blockage. And if we would look in the way we looked under the microscope with that other patient, we would see that similar filling of the space where blood is supposed to flow in the artery. Now, possible causes of coronary artery disease, possible causes in cancer survivors. So excess radiation to the heart. And as I mentioned, for breast cancer, this is a rare, very rare problem in the modern era of radiation therapy. But other risk factors that can come up, well, age is always a risk factor, family history, obesity, physical activity, inactivity, tobacco, high blood pressure, diabetes, high cholesterol, things we mentioned before. Symptoms, chest pain. There's a typical angina pectoris, it's called, and a typical type of pain, but even other pains can be worrisome for coronary artery disease. Shortness of breath, excess fatigue, extreme dizziness. Now, again, I like to point out that these symptoms are quite common, mostly due to other things. And of course, cancer survivors have a number of reasons for fatigue, dizziness. So again, I don't want you to jump to the conclusion if you have this symptom that you have coronary artery disease, but it is something to be aware of and something that doctors, when we see these patients, we'll need to check if the setting seems right. Again, there are tests, the basic stress test, coronary CT angiogram is a great new method, newer, I would say, to look at these coronary arteries. And then cardiac catheterization, where tubes are put into the arteries in the leg or the wrist, advanced to the heart, and X-ray dye is injected into these coronary arteries, and we can see where blockages are, how many, how bad, that kind of thing. If there is significant blockages, then there are treatments, number of medications, coronary stents, and even coronary artery bypass graft surgery. Just to show you, this is a stent. So if you look on the top, you can see the blockage. You can see a compressed stent passed into the blockage. There's a balloon inside, and when the balloon is inflated, the stent stretches out. And then when the balloon is removed, the stent stays there, and you have to kind of imagine this in 3D, but that circle that we showed in the normal coronary is back again because the blockage has been pushed aside and the stent is now there to keep the artery open. This is a picture of what a stent can do. It's maybe hard to see, but this is one of the arteries, and you see kind of a normal, this is with dye, this is the catheter. dye is injected, X-ray dye runs into the artery, looks fine until we get to this point where you can see the artery is very narrow, restricting blood to this section of the heart. So then a stent's placed, and lo and behold, the artery is back open again. So again, just some reassurance that if problems show up, they can be treated, and so that when you hear these terms, stent, you'll have maybe a little better understanding about what's involved. So problem number 3, blood clots. So this is a diagram of veins, popliteal, or the veins that are in the leg. Now you all remember the arteries carry blood to the leg, and then once the blood goes through capillaries and oxygen extracted by the muscle and skin and bones, then the blood it goes back into the veins and is sent back up to the heart. And these veins all have names, but these are veins in the legs. So what can happen is a DVT, so deep vein thrombosis, DVT. So this can form, this is in a femoral vein. So now the blood trying to get back up to the heart encounters a blocked vein. Well, there are what we call collateral, sort of detour veins that can go around this, but they're not as effective as the main veins. So blood does get back to the heart, but at the price of sometimes pain and swelling in the leg. If the blood clot in the leg breaks off and does get to the heart, like this blood clot, and then goes through the heart out into the lungs, this creates what's called a pulmonary embolism. And the blood clot here can actually block off blood flow to a section of the lung. And this can be a very serious and actually sometimes fatal problem, depending on the size of the blood clot and how much of the circulation to the lungs is blocked off. So deep vein thrombosis and pulmonary embolism causes in cancer survivors. So physical inactivity, prolonged bed rest, hypercoagulable state, meaning that in some cancers, proteins are released which make the blood clot quicker than it would otherwise do, and that increases the risk for clots in the veins. Some types of hormone therapies, tamoxifen, for example, does increase the risk of blood clots. Now, some of you may have taken or been on drugs like tamoxifen, but I'm sure the risks of increased chances of blood clots was explained. Like all medicines, there's balancing the risks and the benefits. So it's not common, but still it's something to know about. The symptoms we mentioned with deep vein thrombosis, leg swelling, pain, and redness. And for pulmonary embolism, shortness of breath, chest pain, bloody sputum, and as I mentioned, it can be a fatal complication. Tests are available to diagnose this. So ultrasound of the veins in the leg can find clots. Pulmonary CT angiograms can find clots in the arteries in the lungs. And there are treatments, anticoagulation. The 50, 60-year-old standby was Coumadin. I'm sorry about that. Let me pause for a minute and that'll stop. I have all the automobile warranty insurance I need. If you all are interested in some, I can direct a call your way probably. Okay. So, but nowadays, in replacing Coumadin, there are a number of direct oral anticoagulants, Eliquis, Xarelto, Pradaxa, and others that we use, which are effective in treating and preventing blood clots. If very large blood clots go to the lung, then other measures are sometimes needed, such as clot buster drugs to dissolve the clots, or even retrieval of the clots by catheters or surgery. We talked about what can happen, and now I'd like to move on to talk about prevention. I mentioned risk factors for developing disease, and this is risk factors for breast cancer. And you all know these: family history, the BRCA mutations, and others, advancing age, physical activity, obesity, tobacco use, excess alcohol use, are all risk factors for developing cancer. What about risk factors for coronary artery disease? Well, interestingly, there are many that overlap. Family history, age, physical activity, obesity, tobacco use all contribute to both breast cancer risk and coronary artery disease. And of course, there are others with coronary artery disease that we mentioned before: cholesterol, blood pressure, diabetes, stress. So I like to emphasize that of these risk factors for both breast cancer and coronary disease, some we can't help. Our family history, that goes with us being born. Our age, that goes with us being people. But a lot of these risk factors are to some degree under our control, and that's what I want to speak about from the rest of the talk. So what about exercise? Amazingly, Americans who do no physical activity, percentage of people who reported no leisure time physical activity. 2 or 3 decades ago, only 19% of women and 11% of men said they did no physical activity. Amazingly, and this is already a decade-old data, but half of women and almost half of men report no leisure time physical activity. So amongst the benefits of our technologically improving society are that we don't have to walk at work, and many people don't exercise at all. Physical inactivity increases the risk for many chronic diseases: cancer, cardiovascular disease, stroke, hypertension, heart failure, diabetes, obesity, osteoporosis. What about the effects of exercise-based cardiac rehabilitation in patients with known coronary artery disease? And the reason I'm showing this is I want to impress on you that physical activity benefits the heart. And there are a lot of studies that show this. This was just one that they were able to kind of control it with either people were told go out and exercise, or they were enrolled in cardiac rehab. And what was found out, and this is a meta-analysis of 48 trials. Meta-analysis means summary of 48 trials, so a large number of patients. And what was found was that exercise lowers blood cholesterol, lowers blood triglycerides, which is another fat in the blood, lowers systolic blood pressure, that's the top number of blood pressure, lowers rates of smoking, which is good. And the end result was, with exercise-based cardiac rehabilitation, 20% lower mortality. Now, so that's pretty impressive. Now, I got a question which I thought was very insightful, I think last year. And the question was, 20% seems like a lot lower. And I want to try to make a small statistical point. And that is that these 20%, these numbers I'm going to show you are relative lower mortality. So let's just say, for instance, there's an intervention. Let's say there's a situation, let's call it, I don't know, diabetes or high blood pressure or something that it causes 10% risk of death. And now we treat the high blood pressure and the risk of death is 5%. Well, that can be expressed as an absolute risk reduction of 5% or a relative risk reduction of 50%. And authors like to use the relative risk reduction because it makes the results more impressive. So I don't, this is not statistical course. And in fact, I've probably just taught you about 75% of statistics I know, but it is something to remember when you're seeing this number or numbers like this. Well, we just talked about how exercise is good for the heart. Well, how about exercise during adjuvant chemotherapy for breast cancer? Does exercise help the heart? And in fact, as you can see, this is disease-free survival. And it's pretty good over 5 years, or this is out to 8 years. And survival is pretty good. But for people who exercise, survival is better than for those who don't. So it's a reason to encourage people to exercise. Now, another astute question that I think your group has asked is this cause and effect? And you all are probably savvy enough to know the difference between association and cause and effect. And particularly with something like exercise, it's hard to know because you might say, well, women who are burdened by metastases or have more extensive surgery or more lymphedema, they might exercise less and they might be at higher risk. And it's not absolutely a proof that more exercise reduces the risk of dying from cancer. Maybe healthier women die less than women who are not as healthy for other reasons. So I think nobody can prove that, but it is important to note that it does happen. So and there may be some cause and effect here. So I encourage people to exercise both for the heart and for their cancer. So these are, again, relative numbers, but the benefits of exercise in patients with cancer. So improvement in survival for cancer patients who've exercised. This is from a fairly recent study, 37% improvement in survival. Improvement in disease-free survival for women with breast cancer, so more specific to your group, who exercised during adjuvant therapy, 32% relative improvement in disease-free survival. So good signs pointing to good outcomes when you exercise. Cause and effect, hard to know, but also hard to ignore the data. So people say, how much exercise should I do? And so there are a lot of kind of complicated directions for this. I find that most patients and most people like me want something fairly easy to remember. And there is data to say that 150 minutes per week of moderate activity is a point and if you do that or more, there is demonstrable benefit in terms of reducing coronary artery disease and improving survival. So I like that as a cut point to advise to people. 300 minutes is better, but 150 minutes is a good goal. And how does it happen? So next slide, what is the moderate activity? And here's a list of things. So walking between 3 and 4.5 miles per hour on a level surface, hiking, bicycling at 5 to 9 miles per hour on a level surface, aerobic dancing, water aerobics, yoga, stair climbing, ballroom dancing, line dancing, swimming. So there are ways to do this that can fit into most people's, I don't want to speak for everybody, but a lot of people's, there are options available. That 150 minutes, you can divide it up. So 5 days a week, 30 minutes a day, that's good. People say, well, what about doing 15 minutes twice a day? That's fine. You can break it up into smaller increments. But think about the 150 minutes a week. That's where it should add up. Well, obesity. And so I want to give a nod to all of us in the pandemic, but everyone's quarantine diet has actually been helping with the social distancing. And I thought this made some sense if you're like me, fighting, having to stay inside is tough. So, so what about adverse cardiac effects from obesity? So high cholesterol, diabetes, high blood pressure, congestive heart failure, something called the metabolic syndrome, sleep apnea, deep vein thrombosis, pulmonary embolism, all higher in patients who are obese than those who are not. And what about obesity and its relation to breast cancer? So the relationship of weight to total mortality after the diagnosis of breast cancer. Again, a meta-analysis of a large number of studies. And you all probably know that BMI is a way of trying to normalize its body mass index, normalize weight to height. And so BMI over 30 is considered obese. So you can see that as BMI goes up, RR means relative risk. So it means the relative risk of mortality from cancer goes up. So if you take a normal risk as 1 in a group that is not obese, you can see that as weight goes up, the risk goes up to 1.5, which is 50% higher, and even higher with people that are what we call morbidly obese. Now, this is what's called a J-shaped curve, meaning as the weight gets low, the risk goes up as well. And this is something that's speculated on. I think probably the most obvious thing is, in this case, it's breast cancer. So women with metastases tend to lose weight. And that may be why there's this J-shaped curve. So. Well, we talked about obesity, so let's talk about the benefits of a healthy diet. So this is an unhealthy diet. Hamburgers, cheeseburgers, hot dogs, pizza. This is a healthy diet. Oily fish, salmon, nuts, whole grains, fruits, vegetables. So which diet? And so I get asked that, and okay, doc, which diet should I go with? Well, there are a lot of diets, and I'm going to give you a recommendation, but just know that there are many, many diets. And I'll tell you the principles of diet that I think one should check for when they're picking a diet. The first principle is, am I going to be able to stick to it? And some are better at that. Some people are better at that than others, and some diets are more appealing to people than others. So factor that in. I ask people to factor that in as they choose their diets. So this is something I know you can't read, but there is some science behind healthy foods. And what this means is this line is right on 1. And we talked about risk reduction or relative risk. So this is risk less than 1. So these are whatever diets or foods fall in here is good. These are risks that are more than 1. And so whatever foods fall in here are bad. And so if we go to the next slide, you can see, maybe you can read this, but the foods that fall in the relative risk, which is lower than 1, are the ones in green. So fish, fruits, vegetables, nuts, whole grains, green tea, coffee. And these are some diets, DASH, AHEI, Mediterranean diet, prudent diet. The reds are things to avoid: processed meats, refined grains, sugar-sweetened beverages, and in general, Western diet, which is the picture that I showed you before. So that's the heart. So what about diet intervention for breast cancer patients? So there's a women's intervention nutrition study after treatment for early stage breast cancer, and patients were divided into those that rigorously ate a low-fat diet and those whose diet was not as controlled. And you'll see that the improved relapse-free survival was 24%. Another study called the Women's Healthy Eating and Living Study during treatment for operable invasive breast carcinoma, low fat, high vegetables and fruit, Overall, no benefits, kind of disappointing, but in what are called hot flash negative women, which I think means postmenopausal, had recurrence reduction was statistically significant at 31%. So the point is diet, good for the heart, good for treating patients with cancer. So Mediterranean diet is one I like because there is some data, and so there are certain key components. And you know, this came from, it's called Mediterranean diet because some countries around the Mediterranean, France, Italy, Greece, Israel, Spain, when checked, have lower incidence of coronary heart disease than other countries like Scandinavia, the British Isles, and US for one. So a lot of work went into trying to figure out what were the important components of the Mediterranean diet. And here are some that you can remember, and these can be extrapolated to other diets as well. But eating primarily plant-based food, such as fruits and vegetables, whole grains, legumes, and nuts, replacing butter with healthy fats, olive oil, canola oil, using herbs and spices instead of salt, limiting red meat to no more than a few times a week, eating fish and poultry at least twice a week, enjoying meals with family and friends. So it's a recognition that social camaraderie is good for our health, drinking red wine in moderation, and getting plenty of exercise. Smoking, I don't think I need to tell you that this is a slide, this is about the heart. So the more cigarettes per day, the more coronary heart disease mortality. But cigarette smoking in patients with a history of breast cancer increase in risk to continued smokers compared to non-smokers. So the risk of recurrent breast cancer, 41% higher. Risk of death from breast cancer, 60% higher. Risk of death from any cause, 100% higher. So heart disease and cancer reduced by smoking. I think lung cancer gets better when you don't smoke. I won't spend time on that. High blood pressure. So this is just another slide. So this is systolic pressure, top number, 140, 160, 180. And the degree of increased risk of heart disease, if for all ages, the higher the blood pressure, the increased risk for heart disease. Treatment for hypertension works. And again, we won't go into a lot of the details, but this is just one of many, many studies. So what you can see is this is cumulative hazard. So it's the hazard for cardiac problems, just to sum it up. And with standard treatment, this is the risk. With intensive treatment of blood pressure over years, the risk is less. So treatment of high blood pressure for the heart, quite important. So cardiovascular disease claims 500,000 women's lives every year. This is American Heart Association Learn and Live literature. Cardiovascular disease kills more women than the next 7 causes of death combined. Breast cancer kills 1 in 30 women. Cardiovascular disease kills 1 of every 2.5 women on average. We talked about the risk factors that are under our control, and this leads to the American Heart Association's simple 7 steps. So get active, control cholesterol, eat better, manage blood pressure, lose weight if you're obese, reduce blood sugar, stop smoking. So just to remind you again, Levine Cancer Institute Department of Supportive Oncology clinic. We're in LCI 2. I work with Dr. Jay Singh, who's at Sanger, great young guy, very smart, just so you'll know about us. And that's the end.